Swarup, it is visible now. Swarup?
Am I audible now to answer to this, maybe at the end of the session? So there is a patient named X. I haven't mentioned the patient's name. So this is very confidential. Anytime when we present any cases in the group or to the new people, apart from the team whom we are working with, so you may have to just mention it as a subject or the patient, do not mention the name. So I haven't mentioned the name here. And this is a patient with a case of carcinoma of right breast with the infected wound and lung mets. I repeat that again. So this patient is with a carcinoma of the right breast with the infected wound and lung metastasis. So the question is like her performance is 20%. So, and also she's experiencing a lot of severe pain. The pain somewhere is scored by using her the facial expressions. We call it as a flag scale. The irritability and screaming. Sometimes the patients even mourn just in pain. So based on that, we have taken the pain assessment and the pain experienced on the chest region. Followed by that, her performance is very poor. I think we all know that about the performance, right? Though which is around some 50 performance is nothing but they can do things on their own. They are a little bit dependable, often dependable. And the PPS per 20, which means that the patient is not doing well and the patient is completely dependable. So there is nothing you can do with this. Maybe in that situation, what are the things you have to do is to be mentioned on. And also the patient is having a little bit of breathlessness and very anxious too. So she's in a state where she couldn't decide, not the family even could come forward and decide of what is happening to her. So the next point what I mentioned is, the patient is from the poor family background and residing in a very remote area. Like I told you before, a lot of our patients whom we see are from a very poor background, poor and very poor background, which means that they don't have money to eat even. So you can't be dependable on such patients. So you may have to concentrate more on such patients in managing their symptoms, who is with a PPS of less than 20, I can say. And so the question is, how can we help this patient and family in their suffering? So this is what the question rises for this. And what kind of health education can we provide to them? And how to provide the good quality care and comfort during her end of life. So this is just a case scenario of one of our patients suffering. Just assume that this patient is with you right now. So whoever is a participant, I want just you to think about it. By the end, I would like to like the whole team to just come out with a lot of questions. So that will be a good interaction even. So how do we provide good quality care and comfort during her end of life? So the only thing what we do in our palliative care setup, when you see the patient in the end of life situations, so there are a lot of things what you may have to do. See, this patient is with the poor performance, which means that no corporate hospitals, no private hospitals are going to take her up in that situation, just because of one single reason, that they don't want the death to happen in the hospitals. That's a point number one. And the second thing is, they don't really know how to manage such situations. So palliative care plays a major role in the patients in the worst quality care. So this is a time where you have to think about. So what I feel is, you may have to have a very good care plan. Even in the last session, I talk about that. You should have a good care plan of action. So the whole team should come together and discuss about what is happening, what are the good things you can do for her. So we are going to go in detail about what it is exactly. So planning about how to change the medications for the patient who is unable to take orally. So for example, the patient with the performance of 20, which means that this patient can't take any oral feedings, nor the medications even. So you can't depend on the patient taking some tablet medications in the tablet form, nor any other form. So better to try to go in a way that which is more comfortable for her and relieve the symptoms. That is your main goal of action to be. So what exactly you're going to do is nothing but the subcutaneous infusion. So this subcutaneous infusion is nothing but, the first point I mentioned in here is, it's an alternate route to the IV and IM or subcutaneous injection. So the subcutaneous injection is administered as a bolus into the layer of the skin. So this is just directly introduced, just like an IV cannula. You're not going to introduce the cannula directly into the vein. It just remains under the, just beneath the skin, which remains in there. So that is below the dermis and epidermis. So it is highly effective in administering the medications. So one of the best policy or the protocol in the subcutaneous route of injections is nothing but the patient feels more comfortable. You need not change the. So I'm going to talk about that more in detail. So frankly to say, it is not a big deal. Like not a big discussion like earlier we had about the colostomy, not the lymphedema or any other wound management. But somewhere it is important for all the palliative care team, including the doctors and the nurses, to learn more about how to administer the subcutaneous injections, how to fix the subcutaneous port, how long it stays on. So we're going to learn more in detail about that. So this is a basic, the picture what you're seeing now is a very basic butterfly needle using a wing set, which introduced directly under beneath the skin for a very short period of time. In emergency and you don't have any access to that, you can go for this, because this butterfly set needle is more easily available, and struggle not for that to get it available there. So this is one type of subcutaneous port. So the blue colored, the violet colored needle and the wings of that is going to remain just under the skin, and the tubing will be folded up, and the opening or the other end of the tube is just left open to introduce the medications directly or push into that. So I'm going to just share one other picture of the 26 gauged IV cannula. It's a very small one. We just generally use it in pediatric wards for small kids to introduce some IV cannula into that. But the question is, the same cannula can also be used for the subcutaneous route even. So it is very small, a small little prick, that's all. It doesn't be more painful, and followed by that, it can just remain in there for a long time. It's more beneficial comparatively to the other butterfly wingset needle what we have seen before, because the patient and the family might be tensed or worried about the needle inserted into the subcutaneous route or subcutaneous port. So sometimes comparative to this, the patient may become panic about that even. So to prevent that, this is one of the best idea we do it. In Canada, in my experience, I have seen very big, very large port, which is just introduced just like the butterfly set needle, but it is just a plastic which remains into that needle, just drawn up again, and it remains in. So it is more visible and more comfortable, and it stays long even. As we don't have those access of that particular ports available in India, so we are going to use it directly with the IV cannula of 20 gauge needle. And so this is about the drive fixed into the IV tube, and you can see there is an infusion pump which is placed in a green colored cloth with the IV set cut off at the site of the regulator, and it is fixed directly to the syringe. I'll share that again with you. And on the other end, it is going to be fixed with the needle. What you see, it is going to be fixed into the subcutaneous port directly, so that the medication would be administered in a proper way to them. Just keep it in mind. This is another picture of the material what you have seen earlier now. So this is about the continuous subcutaneous syringe drive. So this is about the medications what we have planned. For example, let us go back to the first slide of the case scenario what we have seen. There is a patient with a poor performance who could not take oral medications, and followed by she's experiencing a lot of pain and anxious, and she also developed breathlessness. Due to the cancer itself, we all know that most of our patients who are with the carcinoma of breast may experience pain and breathlessness. It is just because of the local spread of the disease itself. So there will be a metastasis to the lungs, or the ascites would also be the cause of their breathlessness. So that scenario, in that same case, you can see there are a little bit of information which is shared on the screen right now. Over the syringe, there are some medications placed in. I hope you all can see that. So there are a few medications like morphine, a little bit of midazolam. The doses were also been mentioned on that, and a little bit of haloperidol to reduce that level of confusion. And sometimes the patients may get into delirium. just because of the decreased performance itself. We all know that end of life delirium is most common. So to prevent that, we also have added haloperidol. There is another reason for adding that, because the combination of the increased doses, not the sedation, or when there is refractory symptoms, which means that the patients may experience a lot of confusion. So the combination of these drugs are more important. So all these drugs together are placed in the infusion pump and fixed it directly over the subcutaneous route. So which helps in controlling the symptoms, the multiple symptoms what the patient is experiencing. So there are a few drugs which are combined together. This is just wanted to show you about the continuous subcutaneous infusion. You just have to fix it and start it now, and it goes on for the time being. It can go up for more than an hour, starting from that period of time to 48 hours. So it's more comfortable for our patients. So the question is, so why do we give the subcutaneous injections? What is the point of giving the subcutaneous injections? When people may even think about uh, the IV infusions, as it is most common, all the other private hospitals have been practicing the same process. So how good those IV infusions are, how good those subcutaneous infusions are. This is what the question rises for every one of us. Even many times when I've been to the private hospitals to see most of our patients who are applicable for palliative care, I see such situations where they go for the IV route. So one problem with the IV route is it may not stay long for on the patient's side, because you may have to frequently change more of infections and it get blocked, and there are few drugs which are not to be given. So that is the reason it is important for you to understand, why do we go for the subcutaneous route when we have the other routes available? Why not intramuscular? Why not the intravenous? This is what the question rises for us. So the first point I have mentioned here is it can be used to give many types of medications for various medical conditions. So think about this point where I'm going to stop or just hold on for a while. So you just try to add a lot of medications together. You can't place it anywhere. So there are few drugs which are incompatible. So compatibility is nothing but there are 2 drug and 3 drug compatibility. You can go through the drug formulary books where you can get the information available there. There are few drug compatibilities like the morphine or the midazolam can be mixed together, because these two are the alkaline drugs which can be mixed together. There is a compatibility. With the combination of haloperidol, it's a good drug of choice. Like many medications can be given together, and there are few medications which should not be given through the IV route. Just assume that. Just think about the morphine administering in the IV route. So what does happen when you administer IV morphine in the IV route? So generally what happens is morphine reduces the respiratory rate. So just give me a break for a minute. Okay. So here comes, I'm sorry about that. So morphine generally when you administer intravenous, it reduces the respiratory rate, and you don't really get an accurate value of the pain or the comfort. So suddenly the patient's condition may become a little bit worse and may become drowsy. So to prevent that, the medications like morphine, haloperidol, and the and midazolam, these are the few drugs which are to be a little bit careful, and you should not administer in the IV route. Maybe for a time being, when the patient is having a lot of pain, I see some disturbances there. Try to please mute your phones, please. So somebody have unmuted their phones. Please, that would be a little bit of disturbance for others. So just keep it in mind. Okay, I'm going back again. So there are few drugs like few benzodiazepines and some opioids which are not to be given in the IV route, because you see the rapid response happening, like more of side effects would be seen.
Sir, you are muted. Swarup? Sir? So can you
Sorry.
hear?
Yeah. Yes. Got it.
Yeah, yeah.
I think my screen has gone. I don't know why. So it is like the medicines like morphine and other drugs which we use are more compatible, and it is easy to administer through the subcutaneous route. The second point has mentioned is the patient who cannot take oral medications and who are in the semi-comatose state. This is the best option of for most of our patients. Like who cannot take oral medications, you can go up to parallelly. You can just shift to the subcutaneous route, because it really makes sense when instead going for the IV, you just have to administer medications and teach the family about how to go forward. Like all our patients whom we see does not stay back with us for a long time. One day they have to go back home. So we have to just teach the family about how to administer. That is what we do here, because a lot of our patients, the family may say that we don't want the patient to be in the hospital anymore. We wanted the patient to be taken home again. So if that is how the situation is, we may have to teach the family. In that way, it is more helpful in administering medications. So family education plays a major role in that. So it also helps in to have a continuous flow of medications and avoid the delay. When you start putting them on the infusion, you just have to only thing you have to do is you just fix it up and it can just go on, run on. So there are a few things or protocols which we have to go through when there is a continuous infusion. So I'm just trying to mix two things here. When you put a subcutaneous port, there are drugs like morphine, midazolam, diazepam, and lorazepam, and all these drugs like metoclopramide, ketorolac, paracetamol. Many of the drugs can be given through the subcutaneous route. But here the question is, how do you connect to the infusion pump? So there are drugs like earlier we have seen mixture of drugs together. Assume that this patient is in the hospital now. One day he's going to get discharged. When he's in the hospital setup, when you fix all these medications, only thing you have to see is look for how good the drugs are working. So frankly to say, what things I have learned, in my experience is, once you connect some medications to any of such patients, only thing you have to see is look into how good it is working. For a period of time for 6 hours, we fix up the drugs and look for the changes happening there. If the symptoms are under control, we can continue the same medications for next rest of the time. And if the symptoms are not under control, in that period of time, in that 6 hours, you are going to change the drugs into by increasing the doses, because it is called as a refractory symptoms. There are few symptoms which will not be under control even though you are administering the medications. So you have to look into that. So it can be continued for 6 hours, nor you can increase it to 12 hours if the patient is comfortable. Meanwhile, you have to look into the level of drowsiness, the level of comfort. Try to make um, the changes happening. Observe the changes happening in the patient side. So that is what you have to do. So it helps to have a continuous flow of medications, avoiding the delay. So avoiding the delay is nothing but when you connect an infusion pump, it gives away information, and also it relieves the pressure of the nurse there. So the drugs compatible, mix it together and administered. If that is not under control, you are going to change. If it is under control, you just have to fix it, monitor it every hourly, look for the responses happening. And when the drugs are administered, just a minute, please. So when the drugs are administered, uh, sometimes it will be delayed when it is administered 4th hourly or the 6th hourly doses. So to prevent that, sometimes when there is a lag happening there, the patient may experience the high level of integrity of symptom. Either it would be pain, breathlessness, or anxiety. So to relieve that, the infusion pump as the drug will be continued instead of stopping the drug, or sometimes the nurses are busy and they don't administer it in time. So to prevent that, it will be more helpful. And our last point is the drugs with the 3 compatibility can be given through this route. So the mixture of all these drugs together. So this is an advantage in the palliative care nor the infusion pump. So you can just administer different types of drugs like morphine, midazolam, and haloperidol. You have seen for the different symptoms. We are just trying to administer all the medications together and run those. And next slide, please. Next slide, please. Yeah, thank you. So the question is, what drugs can be given into this route? Like I discussed before, the most of the drugs used in palliative care are can be given through this route. Like I told you before, I'll just remind that again. Like morphine, midazolam, metoclopramide, and diazepam. Paracetamol can also be given through the subcutaneous route, and ketorolac and few NSAIDs also can be given through the subcutaneous route. And there are a few things which you have to keep it in mind. And the drugs like the drugs which are in the powder form, we dilute it and administer through the IV. The drugs which are in the powder form are not supposed to be given through the subcutaneous route, because it just the water for injection, when you use the water get absorbed into the subcutaneous route, but the powder remains in beneath the skin, so it forms a layer again. You see a lot of extravasations happening. So never ever try to administer the drugs which are in the powder form into that route. And also during the administration, the nurses or the doctor has to look into the pH level of the drug to be checked before administering. Like I specifically mentioned before, the pH, either the drugs are in the acidic form, nor those are in the alkaline form. Have to look into that, because there are few drugs which should not be given subcutaneous, because to prevent that extravasation, drugs are to be a bit confidential of before you administer, because on the ampule itself or the vial itself, you can look for the compatibility or the drugs administered through that route. So go and try to follow that. So you can get into the drug formulary and look for which drugs are to be administered through the subcutaneous. Unless it is not preferred, you're not supposed to give. So including IV fluids also can be given through this route. So the time when the patients are in a very bad state, we all know that infusions or the hydration cannot be helpful. But in the situations where the patients or family are forcing you to do that, to administer the medications or the infusion, it's important for you to go. Or the patient is more dehydrated and you're getting access of the IV route, and you can go for that. Only thing is you have to monitor that and regulate the flow of the fluid what you have connected. How to regulate that is nothing but when you start on the infusion or the IV fluids, things you have to check is there will be a huge local swelling over the port side. So which means that there is a lot of flow happening there. So you have to regulate it and try to manage it for more than 12 to 18 hours and make sure that it is going very slow, and it is not going to help the patient. Unless it is dehydrated, it is not going to be more helpful. Just have it in mind. So there are 2 and 3 drug compatibility has to be checked before administering, because there are few drugs which are not compatible, and when you mix those drugs together, you see some crystals or colloids forming in the infusion. So make sure that these drugs are not be mixed together. Like ketorolac is a drug which is not to be mixed with the other drugs. Even drugs like oil preparation of paracetamol or diazepam should not be mixed with other drugs. So there is no compatibility with that. So look into the 2 and 3 drug compatibility before administering the medications. Next slide, please. Yeah. So which conditions do you prefer the subcutaneous route? Is the patient's experiencing intractable vomitings. So this is a situation. Yeah, I hope I'm audible for everyone.
Yes, you are.
Thank you. Thank you. Meanwhile, I'll be just poking you to make sure that things are all right. Yeah. Okay, so the patients with the intractable vomitings, so whoever it is, I'm not talking about the patients in the end of life, but the patients who are even with the performance of 50, which means that they're active and oriented. Even such patients also with the intractable vomitings need an alternate option for them. So in such situations, because when there is a patient with severe pain and vomitings, you can't administer oral medications, nor the morphine, neither the metoclopramide, nor any other antiemetics too. So in that situations, you have to convert the route of administering medications, and the easiest method and the best method is nothing but uh, the subcutaneous route. So number two, uncontrolled pain and could not tolerate for oral medications. We even face such kind of situations where the patients who are taking oral medications, there you see the pain is not getting controlled. If that is how the situation, try to convert it. I can give you an example. Like yesterday, I have seen one patient who is with the head and neck cancer. He couldn't swallow. Very, very hardly is trying to swallow a little bit of oral feeds and some kind of medications. And his pain is not under control. Nurses are administering the oral medications more and more frequently, where they don't see any kind of such changes happening. Still, the patient is having severe pain. What I suggested them is convert it into from the oral form into the subcutaneous form. Yeah, there was a little bit of changes and more of the breakthrough doses were given. So it is nothing but skipping of medications from one route to the other route, which gives a lot of changes in controlling the symptoms. So that is what uncontrolled pain, and the one who could not tolerate oral medications, you can go for the subcutaneous administration of medications. And the patients who are in the semi-comatose state, generally when you go up to the private sector, people may put you directly into a ventilator, nor the ICU, and put them on the IV medications. So instead, when you talk about the patients in the palliative care unit, only thing you have to think about is how am I going to improve the quality of the patient? When you just have a thought about that, you can just see for the good resources, number one. Number two, the judgment of what exactly can be helpful for the patient. Third thing is it going to be helpful for the patient? So in that state, the semi-comatose state, even this is the best choice of administering medications, and even hydration can also be given as a lifeline. So the next point is the uncontrolled breathlessness. As I told you before, the patient with the poor performance and the uncontrolled breathlessness, they can't take any oral medications. You can't even insert the Riles tube because it's not a patient's choice to go for that. Assume that there is a patient with the good performance, active and oriented. When you're talking to him, he told you a lot of things about, please don't introduce a Riles tube. Please don't insert a catheter to me. Don't hurt me a lot. So this was the things happening when the patient was comfortable. When his performance is becoming bad and worse, one day there is a choice for you to think about, this is not a good thing what you can do. Do not try to go for that, because when you talk about the ethical principles, doing good for the patient, number two, is that going to be beneficial? Are we doing harm to the patient, not the justice? So when you have these things in your mind, you don't go for that. So when you think about the advantages, the subcutaneous port is the only option for us at that time. So try to put the subcutaneous port. All the medications will be given through the same route. And last point here, patients with the subacute intestinal obstructions. Sometimes you see the feces coming out from the mouth. They don't expect that. That's called as a fecal vomitings. So they haven't expected, like earlier I told you before in the discussion on the colostomy, the patients vomiting, emitting the feces from the mouth. So which is very horrible to say. It is more disgusting and weird for many of our patients. So maybe in that situation, go for the subcutaneous injections so that the patient need not take any more oral medication. Sometimes if there is a patient choice, wanted to have something for his refreshment, you can go for that. So these are the conditions where we prefer subcutaneous port. Next slide, please. So what are the benefits associated with the pain management? Earlier, I have touched the same point again. So I'm going to touch this more. So can be used for the patients with the poor venous access. Many of our patients with the cancer, there is a poor access to the vein because already they have undergone more of chemotherapies where the drugs administered and the veins are more extravasated, and it is more of putting more pain to the patients. So we don't go for the IV route, and we prefer the subcutaneous route. This is what the one of the benefit for that, and provide pain relief for the patients who are unable to tolerate oral pain medications. The one who is not able to take oral medications. Would be there other options like transdermal fentanyl patch and transmucosal lollipops, and even local mucosal absorption of the other drugs even. But still, there are few things which you have to think about, because you are converting, you're not changing the medications here, but you're converting the same drug into the other route. That is what you have to think about. So allows the patient to have a greater mobility during that time, and the onset of action is very faster compared to the oral medications. Now IV, as I told you before, it is not going to be more helpful because of the poor venous access. This would be the best option for you. So cost is almost half of those associated with IV infusion. For IV infusion, you may have to call up the nurse or any kind of medical professional to administer the drugs. But subcutaneous port, sometimes even the family were taught to administer that more easily. So it's easy for them, even though the patient lives in a remote area, one family member can learn about how to administer the medications that can be given through that route. Yeah, next slide, please. So what are the things to watch for when you put on this subcutaneous port? Use small gauge winged butterfly needle with a short length needle. Instead, use it in a bigger length. Lot of drug will be wasted underneath. So a small gauge winged butterfly needle can be used. The site selection depends on the patient's activity level and type of medications delivered. So there are few sites where the port can be fixed. For example, I can just give you some sites where this is more helpful. Upper chest, both sides of the upper chest below the clavicle, best site for the patients, as it is more visible and easily accessible. And both sides of the lumbar side can be more preferred, or the less lateral aspect of the thigh, where there is less muscle and more of skin exposed, more helpful there. So these are the sites where you use. And what about the patients who are a bit confused and the patient trying to pull off all the material or equipments which are placed on his body? So the best site for them is both sides of the scapula, because it is not so close to the patient, he can't just pull it off. You just have to place it over the scapula bone and leave it open, put some plasters over there, and it is more safer, and it also prevents the injuries. So site should be free from irritation, away from the bony prominences and waistline. So report complications, and report for few complications, like if there is any leakages happening, redness and discomfort at the insertion site. Yeah, next slide, please. Continued slide again. So on subcutaneous hydration, watch for the local swelling and minimize the flow. When you are administering, there should be a limited or very limited quantity of the drug to be introduced into the subcutaneous port, not more than 1 ml. If you are administering more than 1 ml as a bolus dose, what happens is there will be a lot of swelling over the needle site at the lower end. So to prevent that, little bit of drug has to be taken, followed by check for the local swelling. And the patient and the family has to be explained about the route of administration, because many of them are not familiar about the subcutaneous medications. They feel that it is not going to be worthy, it is not going to be helpful, and they are more happy with the IV route. But it's very important and challenging for the nurses to explain to the patient and family that this is a good choice for administering the medications. So check for the patient's response to the medication even. Check for the response, like when the patient is having vomiting, patient is having breathlessness, not the pain or any other such symptoms happening, try to have a care plan or the chart every second hourly, monitor for the responses. If the patient is more comfortable after 6 hours, you have a documentation evidence that these drugs really help him. If you have evidence where that did not help him, you can just increase the doses as soon as possible. Check the device and its battery power. When you put the patient on the infusion, check for the battery position and the power availability. We have a portable infusion pumps available, and also the power supplied infusion pumps where the patient has to remain in one place. The portable one can be fixed in a for over the abdomen and just move around. The patient can do their own works. And okay, so check for the preparation and check for any kind of crystallizations over the syringe. And approximately 1500 ml of fluids can be given in 24 hours period of time. Yeah, next slide, please. Next slide, please. Okay, there are a few equipments which were required for to fix the port. Number one is about the clean gloves. Use an alcohol swab, wipe it well in a circular motion, leave it open for a while, and some kind of antibacterial skin preparations, whatever you have. Take a 26 gauged IV catheter. Fix it over the subcutaneous area, and the medications in appropriate syringe or a container has to be taken, and medications administration record also has to be maintained. So these are the few protocols what you have to maintain during the course. Next slide, please. I'm getting a lot of disturbances up here. People are calling me for the patient care. Yeah, next slide, please. Okay, there are a few points to remember. So use infusion pump approximately 12th hourly to assess the symptoms, and add if the drugs if required. Because when you put the patient on the infusion, only thing you have to keep it in mind is the goal of action to be changed. Either the patient to be put on the infusion continued for the rest of his life, nor a very short period of time. If that is for a short period of time, you just have to monitor it well and reevaluate it for the changes happening in the patient side. Also, try to involve the family about whether do you think the patient is comfortable with these medications or not, because many may have a thought about these drugs of after starting these medications, the patient's condition became more worse. After starting these medications, his symptoms has become more worsened, and his performance became very bad. So just keep things in mind before you start any kind of infusion or the change of medications or administration route. Just try to explain to the family and the patient about what do you think of this. So I feel that this patient, your patient is very uncomfortable. I wanted to change the medications route. If that is how, let them decide about what to do. Yeah, and this is what is important. So the nurse charting on symptom severity and documentation plays a major role in in this situation. And the care plan preparation and the team discussion should happen. So care plan is nothing but, like I told you before, whatever the symptom which is aggravating the patient, the condition, or symptoms which are worsened, you have to have a plan of action and discuss with the team about this is what is happening. Because change of shift, the nurses may have a little bit of confusion about what we have discussed. So it's important for you to hand it over in a proper way and document it well. Next slide, please. Yeah, sorry, I'm done with this. Shall we take up to the question?
Yes. Any questions?
Any questions, please?
Yes.
Shall we go up to the case presentation then?
Yes, yes. I before moving to the case presentation, I am going to show a video on subcutaneous infusion, then move on to the case presentation. Is it okay?
Thank you so much, Kiva. Thank you so much. I lost my video today.
So we can move on to the case presentation. If you have any, if you have any questions, please put in the chat box. So after the case presentation, we'll try to answer your question. Iba, are you there?
Yes, ma'am.
Yes, yeah.
Hello.
So over to you.
Okay. Shall I start, ma'am?
Yes, yes.
Okay. Hello, good evening. I'm Iba Kantiudukar, working as a staff nurse in Civil Hospital, Shillong. And I'm going to present the case on CA esophagus about a 52 years old male. Presenting complaints, the patient had the complaints of difficulty in swallowing for the past 2 months, and he can take only sips of liquids orally. Loss of weight, general weakness, nausea and vomiting, insomnia, cough. And he came to our facility for the treatment on the 26th of February 2022. History of illness is he was a known smoker with mild alcohol intake, no history of any drug allergy, no past history of heartburn for which he sought treatment at his community health center. On examination, physical and general examination, the patient is conscious and oriented. He looks weak and dehydrated. His BP was 100/70. SpO2 96 on room air, pulse rate 88, his height 155 centimeter, weight 40 kg. Chest bilateral clear, CVS, CNS is nothing abnormal detected, no sinuses, no edema, no hepatomegaly, splenomegaly, and genitourinary is also no abnormality was seen. And treatment and significant investigation to blood transfusion was given for anemia because his hemoglobin is 7.5 gram, platelet count is 3.5 lakhs, urea 16 mg per dl, the creatinine is 1.1 mg per dl, sodium is 140, potassium 4.0, and fluoride 88 mg per dl. Endoscopy was done, and the result is also ulceroproliferative growth in the esophagus. The CT scan neck and thorax also was done. He was known case of carcinoma esophagus. Present history shows the esophageal growth involving the mid-lower third of the esophagus. And biopsy was done. The result was a squamous cell carcinoma showing infiltration into the muscularis propria. And chest X-ray is nothing abnormal detected. It was normal. On medications, he was on injection ceftriaxone BD for 7 days, injection Pantop BD, injection Dexa 8 mg was given TDS, and we are asked to taper every 5 days. On injection Emigo 8 mg IV into TDS, injection Tramadol 100 mg IV TDS, and SOS. He was on IV fluids also, NS, RL, and 5% dextrose with injection MVI into 24 hours, and ORS as tolerated. The psychological aspect, the patient looks weak, worried for his family, decreased appetite. He looks sad with anxiety and fear, inadequate knowledge about the disease, in denial, unable to accept the diagnosis and refuses treatment. Attendant look worried about the patient's condition. Main concern is his generalized weakness, his weight loss. He was unable to eat and he refused the Ryle's tube insertion, insomnia, anxiety, not able to associate socially, anger towards the relatives. The summary, vitals monitored into 4 hourly, the daily assessment of the patient's condition, daily counseling to the attendants, education to the relatives about the importance of nutritional food, and daily counseling to the patient regarding the need for treatment, the psychological and spiritual support to the patient and attendant. Patient wants to be discharged, but due to his weakness, he decides to stay and accept only the IV fluids in the hospital care. And discussion points, proper information about the disease and treatment to the patient and attendant, to check the depression level of the patient, ask direct question about the patient's state of mind, counseling to the patients and attendant in case the patient wants to go home, education about the importance of nutrition and diet, home visit to check on the patient. Thank you.
Thank you, Upa, for the wonderful presentation. Anybody need any more clarification regarding this patient story? Please ask her. Otherwise, we can move on to the discussion points. Any questions? Okay, no questions. So I think we can move on to the discussion points. We would like to hear from the participant side. This patient is, what I understand was this patient is wants to go home because of he's tired and he's on IV fluid because of that intravenous infusion. He is staying in the hospital. So, is there any suggestions or comments on that? Anybody? We want to help to Ipa
Yes, ma'am.
and helping the patient. So he wants to go home.
Yes.
Yeah. So how can we help?
I think what's Swarup said.
I would Iba, I would like to hear from the others side.
Okay.
Swarup?
Yeah, sure.
Yeah. So I'm waiting for their response.
Let us see what people.
Yeah.
talk.
Yes. Yeah. You can put your answers in the chat box. What you would suggest for this patient? So Saraswati said, since he is willing to take fluids, we can encourage for adequate oral fluids. Also, we can try for subcutaneous route for administration of fluids medications. So I think he's right now he is not able to swallow properly. Is it right, Iba?
Yes, ma'am.
Yes. Okay. And the next option we can consider. Then any other answers?
Can you just let me know the performance of the patient? How do you score the performance?
Iba?
The level of disease, the way
Hello?
the patient is fed,
Yeah.
and what about his level of consciousness? Is he able to do his own self-care, or is he completely different? You can just mention those points.
No, hello, sir.
Yeah, yes, please. Go ahead.
Yes, the patient right now is just like bedridden. He can't
Okay.
perform his own, necessities, and he has to depend only on his on the relatives.
That's excellent. Like,
Yes.
as you have taken that initiative to understand what the patient is going through right now,
Yes.
sometimes we don't see for the current patient needs. As a staff, we generally go and try to see what are our needs right now. So it's important for you to understand what exactly the patient is going through. As he's completely bedbound, he might not be able to do any kind of his activities of daily living.
Yes.
And also the reduced feeding, and sometimes he may cough and aspirate just because of the feeding in that position. It's very
Yes.
important for you to talk more about the feeding issues, right?
Yes, sir.
Yeah. And is he conscious enough? No.
Yes,
Is
he's
it?
conscious, but at times I think he looks disoriented now.
So how about the
So
delirium then? I would like to see the delirium score, or what do you feel like? Is he a bit confused?
yes,
If he's
sometimes
confused,
he's confused and sometimes he's oriented when we talk to him.
exactly, the delirium looks the same every
Yes.
time. Sometimes it is mixed kind of delirium
Mixed
where
kind of.
sometimes he'll be comfortable and at the other time he'll be aggravated. Symptoms may get aggravated. Yeah. So that has to be seen. So if that is how the situation is, maybe this IV route of fluids or IV accessibility is not so safe for that patients, right? So
Yes,
better
sir.
to go for the subcutaneous route, and that's what I'm keep telling most of our nurses to have a very good assessment. When you start taking a good assessment, the management plays the simplest role. Unless you don't have a good assessment, the management strategies are not going to be helpful for the patient at all. So when you look into all these aspects and bring it to the team, and it will give you a lot of information, and the management will not be so tough at all for you. And also it is easy for you to re-evaluate even. Yeah.
Yes, sir. Yes.
Yeah. Okay, thank you.
Thank you, sir.
Swarup, on question, can we give subcutaneous fluid to children?
To a limited amount, like even in pediatrics. That's a good question. Thanks for adding that, because I work with neonates and pediatric patients too. There are situations where we have administered IV fluids, limited amount of IV fluids. It's nothing but somewhere around some 100 to 150 ml to run for 8 to 10 hours. Very low dose. And sometimes most of our kids who are put on infusion with the uncontrolled refractory symptoms, with more of cry, aggressive behavior, hitting his head, no sleep at all for more than 3 to 4 days, lot of cry, they're not comfortable, not feeding. There are some situations where the patients were put on infusions. Maybe at that time, the patient would be drowsy. They couldn't take any oral feeds or anything like that, not even the water too. So that situations, we administer subcutaneous fluids too. That is to a very limited amount. So we do it to say it can be done. I hope I'm clear.
Yes. Any other questions? The next question, what about the underweight patient with the less subcutaneous fat? They were asking about the cachexic. So what is about the thin, that underweight patient with the less subcutaneous fat?
Okay. So my other question to the person who have asked for, is it end of life? Nor the performance of the patient is good enough. If he's really in the worst stage or very bad stage, there is no point of administering any kind of hydration, because maybe for the family's sake or the patient's satisfaction or the family satisfaction, we might have done this, or maybe we may do it, unless it is not going to be helpful for the patient, because cachexia is most common in patients who are in end of life. They become more worse, deteriorated condition, end of life. If you feel that the patient is really in end of life, try to look for which is really helping them. Do you think the same infusion or the hydration can help them in that state? Do you think that cachexia is going to bring him back to the normal stage? Not at all. I don't agree with that, because that infusion is not going to help them at all in that stage. So that's the reason why we don't prefer in that stage. If the patient's condition is a little bit active and okay, we can go for that for the time being and look for that. So that is what we do. We try to use some kind of ethical principles all the time. Is it going to be beneficial for the patient? This is one of our ethical principle. Is it really going to be helpful for the patient? Then we can provide it for a time being. And also we observe for any changes happening. So for now, for the time being, you have connected the infusion or the hydration. You are putting on the fluid right now. So did that really bring any change in the patient's perspective? Did he become very active just because of that? Then if that is how the situation, we can continue that. If not, it is not going to be helpful.
So even if the patient is cachexic, if they have a lot of problems like physical symptoms there, if you want to start subcutaneous medications, you can see whether what area is good subcutaneous fat, like abdominal area. You can give the subcutaneous infusion and can select the area, okay, according to the subcutaneous fat there. So better you can, that condition you can take the subcutaneous, around the umbilicus area, abdominal area. So that time you can able to give the medication through. subcutaneously. So if only for hydration, always you think about the ethical principles like Swarup said. If you give injections or subcutaneous that fluids, whether that will be good for the patient or that will be bad for the patient. So always you would think for life. You can think from the patient side, and you can tell the caregivers about the good and bad. Okay, so what are the advantages and what are the disadvantages of that if you are choosing the fluids at artificial hydration? So that thing you would tell the caregivers too. So then they will be able to understand. So so where is the most common site of subcutaneous injection? So I think from the video you have clear on that both side of the arm and both thighs and back below the scapular area and chest and around umbilicus. So these are the common areas which we are able to give subcutaneous infusion. So one more question.
Yes, please.
Eating for malnutrition who subcutaneous difficult because some patient is marasmus. So I don't understand that question. How much amount of fluid or medication can be given to patient into subcutaneous tissue?
Yeah. So 1 ml at a time can be preferable, not more than that, because subcutaneous, because it is having a very poor absorption, you may have to take a lot of time to administer that. Give a break of 10 to 15 minutes and then administer. So 1 ml is more sufficient through that route. So
Yeah.
that's enough.
1 ml, 1 minute. You can give 1500 ml for one site 1 day, 24
Yes.
hours. So as during the presentation, so as mentioned about that 1500 ml, you can give one site. If you want to give more than 1500 ml, you can choose 2 sites. So the next question, how much fluid do you give to children? That
Yeah,
is
mentioned there before.
Yeah.
So 100 to 150 ml is more safer for the patients, the kids with less than 2 to 2.5 years old, and above that, the 250 ml of hydration can be preferred.
The next question is, can we do subcutaneous route for malnutrition?
I don't think so. It is.
Yes.
It is not the correct way, because if it is, see, every time.
You are muted, Swarup.
So is the patient comfortable? Number one. Number two, is the performance doing well? If it is about the good performance and you're looking for the malnutrition, go for the IV accessibility then, because I'm talking about the patients who are applicable for palliative care.
Yes.
Yeah. So
Yes.
it changes.
So always you can always think about the indications of subcutaneous infusion first. So in palliative care here, so most of the time the patient is not, for example, CA esophagus, they are not able to swallow properly. Sometimes we are not inserting tribes tube also. That time you can, if they have a lot of problems there, we can't assess the intravenous line. They need sometimes if you choose intravenous route, you'll give a more multiple times pricks. Should be there so that we can avoid. If you choose subcutaneous infusion, we can avoid the multiple tricks. Okay, and also continue maybe intestinal obstruction. If there is a complete intestinal obstruction there, the nausea, vomiting, and lot of problems. We need to give a complete continuous infusion. So that time you can give a subcutaneous, prefer subcutaneous the route. And also, if there is a mild dehydration there in end of life care or any time, so that time you can choose subcutaneous infusion. So these are the common indications in palliative care. We prefer subcutaneous infusion. That's right, Swarup? Is there any point you want to add?
No, Shiva. Absolutely.
Okay, thank you. So, hope your questions is clear. If you have any more questions, please unmute yourself and talk, or you can put into the chat box. Otherwise, we can wind up the session. Anybody have any more question? Iba, I think you can talk to the patient, and if the patient wants to go home, you can suggest the subcutaneous infusion, and train the patients, train the caregivers about how to remove the needle, and you can put on subcutaneous subcutaneous needle and give one pint of fluid, and train the caregivers how to remove the IV fluid from the subcutaneous SV set, and then send them home, and you can follow up with the home care itself. Okay. So if he wants to go home, allow him to go home.
Okay, ma'am.
Okay. And also he need a good psychosocial support, and family also need a good support, frequent counseling. If you have time, you can give a frequent continuous support to the patient and their family. Okay. I think no more questions. The presentation is clear. I hope all of you understand what is subcutaneous infusion, what are the advantages, what are the disadvantages, what are the indications, and all, what are the sites of giving intravenous infusion. And another thing is the normal saline is the most the safe intravenous fluid which we can able to give through subcutaneous saline. So, but most of the some of the place is giving that dextrose normal saline and ringer lactate solution, but the most common and safe solution is normal saline. Okay, can we wind up the session, Swarup?
All right, Shiva. Thank
okay, you. So no more questions. Thank you, Swarup, for the wonderful session. It was a detailed session. So,
thank you both. Thank you both for
thank you, Iba, for the excellent presentation. Thank you once again for all and okay. We will see you on Monday.
Thank you all. Thank you, Swarup sir, for that wonderful presentation, and thank you, Iba ma'am, for your guest presentation. And I have shared the feedback link with you all. Please go through it and fill it up. We'll see you on the next class on Monday. Until then, bye.